My name is Dr. Ian Storch. I'm a board-certified gastroenterologist and osteopathic physician, and you are listening to DO or Do Not. If you are interested in joining our team or have suggestions or comments, please contact us at doordonotpodcast.com. Share our link with your friends and like us on Apple Podcasts, Facebook, Twitter, and Instagram. We hope you enjoy this episode.
This is White Coat Investor podcast number 368. DOs versus MDs, which is the best degree? All right. Welcome back to the podcast. We have a fun episode today. Got a guest on that we're going to interview. I've been on his podcast, Dr. Ian Storch. He's a DO. He's a GI doc. And I'm going to ask him a bunch of hard DO questions. So we're going to talk a little bit about getting a DO versus an MD, what that means now, what it meant 25 years ago, what it meant 100 years ago. So I think it should be a fun episode. Ian Storch is the mentor and host of the podcast Do or Do Not, which aims at educating pre-medical and medical students and practicing physicians about osteopathic medicine and the osteopathic physician's journey. Ian, welcome to the podcast.
Happy to be here, Jim.
All right. Since I know you, but our audience doesn't, why don't you tell us a little bit about your upbringing and what it taught you about money?
Okay, that may be like a therapy session, but I'll be happy to do that. I grew up on Long Island, and my mother and father were not college graduates. They're sort of working folk. And my mom was always the saver, and my dad was the spender. And growing up, the idea was sort of frugality from my mom, definitely something that she imparted on me. And again, my dad liked nice cars and probably things that he couldn't afford. So I kind of grew a distaste for those things. Ultimately, unfortunate for my wife, that's kind of gone into my current life. I think I'm more, from my mother's perspective, a saver than a spender.
All right. Tell us about your education and career up until this point.
So I never thought I was going to be a doc. I grew up really being, I think my expertise was English literature and social sciences. So I was an English major in college. I went to state school. I went to SUNY Binghamton. It's a New York school where I chose it because I had my parents didn't go to college. I had a cousin who was really smart, who's now my attorney. He's still really smart. And he went to Binghamton. So I said, you know what? Yeah, Heath is smart. He went to Binghamton. I'm going to go to Binghamton too. And somewhere along the way, I had an interest in medicine. I actually saw a car accident. It's a little cliche story maybe, but saw an accident. My roommate was one of these EMT guys with the lights in his car and the oxygen in the back seat. And we got out to help this woman. And, after we saw the car accident, I thought if I'd been by myself, I wouldn't be able to help the woman. So I took an EMS class and sort of, I fell in love with medicine. I decided I wanted to go to medical school. I really didn't know much about medical school, no doctors in my family. So I started studying for the MCAT. And again, I was an English major, so I took some science classes. And I had a Barron's book. And the Barron's book, it was like, they don't have books anymore. Obviously, everything's online. But Barron's book to medicine and dentistry. And it was medical school, dental school. And the last few pages were something called osteopathic school, which I'd never heard of before. So I did some research on osteopathic school, and I thought this is really cool, and this is something I might want to do. I went home, and I actually had a physical scheduled, and I went to my primary care doctor, and I had the book. I showed him, and I said, Dr. Horowitz, what do you think of this stuff? Is this something that's worth doing? Like, what do you think of osteopathic medicine? And he said, I'm a DO, which was like shocking to me. I never even heard of it before. And I said, why do you have Dr. Horowitz on your jacket? And he said, I don't know. People just keep asking me questions over the years. It's a little annoying. So I just took it off my jacket, but it's great. And I think you should do it. So I researched osteopathic school. I thought I was going to be a family practice doc or primary care doc. And a little bit of a long story that I'll skip, but I'll give you a little bit of it. I interviewed at Kirksville. Actually, I wanted to go, if I'm going to do it, I'm going to do it right. So Kirksville is the founder's school. That's really where I wanted to go. I had a girlfriend at the time who was in New York, and she kind of convinced me that I should stay. Needless to say, we dated for another few months and broke up. But that's a long separate story. So I went to the New York College of Osteopathic Medicine for 4 years. And during my rotations, I fell in love with gastroenterology, just met a gastroenterologist who I thought was spectacular. And I said, I want to be like him. I interviewed all over for internal medicine, Mayo Clinic, Cleveland Clinic. At the time, DOs could be free agents, but I ended up staying in New York at North Shore, which is actually where I am now. So I spent 3 years of internal medicine at North Shore, Long Island. I did a chief resident year. I was blessed that they asked me to stay and teach the program for a year. In internal medicine, that's an extra year. And I was blessed with a fellowship at a very prestigious program, University of Miami, which is a spectacular GI program. I spent 3 years doing gastroenterology. I did full liver training. I was able to pack some biliary work, which is advanced training, into that 3 years. And I had met my wife, actually. I dragged her kicking and screaming down to Miami to hang out with me during fellowship. And she said, Ian, I really think I want to go home. So she says, beautiful here. We had a great 3 years. Let's go home. So we came back to Long Island and I joined a private practice. We'll talk about that, I think, a little bit later, but I joined a private practice and that's still where I am.
Awesome. Great summary of a great career so far. Let's get into our subject today. You're the podcast host of the cleverly named Do or Do Not podcast. And today we're going to talk about including the history of osteopathy and how that affected osteopathic education and practice today. There's a few things about the philosophy and history of osteopathy that are a little odd, and I want to hear your take on it. Before we get into those questions, though, I think it's important to point out that the history of medicine itself is not exactly a shining example of a beacon of ethics and scientific practice. When George Washington was dying of epiglottitis, one of his 3 physicians wanted to try a newfangled technique called endotracheal intubation. But the other 2 overruled him. They went with the best treatment of the day, bloodletting. And I'm sure hemorrhagic anemia really did a lot for his epiglottitis. Doctors didn't even wash their hands until the mid-1800s, spreading puerperal fever as they went from corpses to delivering babies without, any time in between. The mark of a good surgeon in the Civil War was whether or not you could take a wounded limb off in less than 10 seconds with a saw. Ether as an anesthetic wasn't discovered until 1846. Anesthesiology before that was a bottle of whiskey and a stick to bite on. Insulin wasn't discovered until 100 years ago. Before that, diabetics just died. Antibiotics are even newer. Prior to Hippocrates, illness was attributed to evil spirits. Hippocrates actually moved us into the imbalanced humors, blood, yellow bile, black bile, and phlegm era. And it wasn't until Pasteur in the 1860s that we even had germ theory. So there's still plenty of things we do in modern medicine that really have little, if any, evidence for them. But with that introductory material out of the way, just to make it clear that we're not in a glass house throwing stones, let's talk about the origin of osteopathic medicine. In the 1870s, frontier doc Andrew T. Still was pretty dissatisfied with modern medicine. He felt the drugs were useless or even harmful. He was probably right about that. So he founded a philosophy of medicine at least nominally focused on wellness, disease prevention, and the whole body, rather than just parts of the body. He wanted to treat causes rather than effects of disease. He was probably highly motivated by the fact that his wife and 3 of his children all died of then untreatable meningitis. So far, so good, right? Then it got a little odd, because Still believed you could treat a variety of diseases by diagnosing and treating the musculoskeletal system. Epilepsy, dysentery, asthma, period-related pelvic pain, digestive disorders, depression, colic. The idea was that there's an osteopathic lesion or a myofascial continuity causing a somatic dysfunction. And you fix the osteopathic lesion through manipulation of the musculoskeletal system, the somatic function will go away. Now, the UK's NHS says there's some evidence to suggest that osteopathy may be effective for some types of neck, shoulder, or lower limb pain, some types of headache, and recovery after hip or knee operations, but there's only limited or no scientific evidence that's an effective treatment for conditions unrelated to the bones and muscles. And in fact, osteopathy was treated as a cult by the AMA in the first half of the 20th century. And in fact, its code of ethics forbade physicians from associating with osteopaths. That's obviously dramatically relaxed over the last century, but DO schools still teach Still's philosophy in some form and still teach every student osteopathic manipulative medicine techniques. So with all of that information out there, As a modern day DO, what are your thoughts about the history of osteopathic medicine?
First of all, that was an amazing summary of 2,000, 3,000 years of medicine in 3 minutes. Bravo, right? Great job. But I think AT still founded osteopathic medicine, as you pointed out. Exactly as you pointed out, we have to put everything in context. So you can't look at a Da Vinci robot when you're talking about medicine in 1870s. As you said, we didn't even know that bugs were causing disease. Penicillin wasn't invented until 1920s, I believe. So we're talking pre-antibiotic. We're talking pre-everything that we have now, as you said, morphine, chopping off limbs, leeches, allopathic medicine was not what it is today. And AT still took a different approach. So the people that came to train with AT still, he was not an MD. So, I mean, he was not a medical doctor. He was a frontier doctor. In the system, there weren't medical schools the way we have them now. When you're talking about the history of medicine in the United States, the Flexner Report, which was a person that reviewed all medical schools and actually got rid of a lot of MD-DO and other homeopathic type schools because of the way that the education was just not what it should be and really standardized everything. That none of those things had come about. So he started practicing this manual medicine, and a lot of allopathic doctors came and trained with him and sort of became MDDOs or DOs, doctors of osteopathic medicine. And the profession really evolved from there. So as a practicing DO today, it's interesting. We're definitely have come a long way from, and this is the 150th year, interestingly. So the profession's been around for a long time and evolved over time, but we're complete physicians. So DOs practice full spectrum of medical care in the United States, which you mentioned the UK. Osteopathic treatment or osteopaths in other countries are different than osteopaths, doctors of osteopathic medicine in the United States. So in the United States, we are complete physicians. We get a medical license in almost every state that's exactly the same as an MD would. The license is the same. There are a few states that have separate DO licensing associations, but most of them, same licensure. I have the same plaque on my wall that you would have as far as ability to practice. And we can go into any specialty of medicine, et cetera, from surgery to family practice, as we discussed. The thing that makes us different is the philosophy, which you mentioned, which we have kept from Andrew Taylor Still, and the manual medicine, which Andrew Taylor Still started, but has really evolved and come a long way since.
Let's talk a little bit about that manual medicine. A lot of people look at it and they can't help but see the similarities between osteopathic manipulative medicine and chiropractic treatment. What do you see as the difference between those two?
So I'm just going to preface with, this is not my area of practice. I am a gastroenterologist, as I stated, but I think the host of DO or Do Not, I'm happy to try to tackle the answer to that question. And I'll give you a little interesting story before we start. So my uncle, I have an uncle who's actually my father's best friend, but we're just going to call him Uncle Freddie. Uncle Freddie is actually a chiropractor. So I grew up with a chiropractor as an uncle. And interestingly, and again, I'm not directly answering your question, but I'm going to come back. Uncle Freddie, when I went with that book, I said, Uncle Freddie, what do you think of osteopathic medicine? I'm thinking about doing this. He said, don't do it. He said, don't do it. He said, you should either become an MD, be a medical doctor, or be a chiropractor. Like, I'm not into this osteopath stuff, which was interesting. And he's come full circle. And I think he fully respects osteopathic medicine after many, many conversations with him. But when you're talking about osteopathic manipulative therapy, which there are a few different terms: osteopathic manipulative medicine, OMM, osteopathic principles and practice is OPP, and osteopathic manual therapy, which is OMT. There are some nuances to those terms, which I may or may not be able to explain to you, so I'm going to bow out. They're all kind of encompass osteopathic therapies. First of all, DOs, I'm going to reiterate, especially in the United States, are complete physicians. And again, to take a step back, I have nothing against the chiropractor. Nothing that I say is negative toward chiropractic. Uncle Freddie is a chiropractor. I love him. But a chiropractor is not a complete physician. A chiropractor only practices manual medicine and is not trained as a complete physician. An osteopathic practitioner in the United States is a complete physician that is trained, takes all the same classes that an MD takes, and has a medical license that's the same as an MD. As far as the therapies go, I'm going to talk about strict chiropractic because some chiropractors do osteopathic therapy. Some chiropractors do physical therapy. So, just talking specifically about chiropractic therapy, as a generality, focuses on spine and the nervous system coming out of the spine. Most of the techniques that people think about when they think about chiropractic therapy are high velocity thrusting techniques, which are those sort of back cracking techniques. DOs look at multiple, and again, we're not talking about philosophy, we're just talking about therapy. DOs look at not only the nervous system, but the lymphatic flow of the body and blood flow. So there's a really thinking about the whole body, sort of everything that you can manually work on by manipulating the musculoskeletal system. The osteopathic treatments range from soft tissue techniques, muscle energy techniques, to high velocity techniques. So there are multiple techniques, and they even go to some sort of advanced techniques, I call them, which would be things like cranial manipulation, where there are doctors that work on the cranium and the sacrum, and there are different ebbs and flows that are felt to affect health. And not all osteopaths obviously practice this, as we discussed at the beginning, but that's the basis. Some chiropractors do craniosacral techniques, but in general, they focus on the spine.
Now, I often tell people on this show, take what you find useful, leave the rest. What do you find useful about the osteopathic philosophy, and what have you chosen to leave where you found it?
Okay, we're going to switch gears a little bit. I'm just going to answer that a little differently. So, as far as manual therapy, I don't practice manual therapy. I'm a gastroenterologist trained at University of Miami. I was the only DO in my fellowship. So I practice the same gastroenterology as any other gastroenterologist, MD or DO would. As far as philosophy, other thing that I think really makes osteopathic medicine distinct is the philosophy. And just similar to talking about chiropractic, I have plenty of MD friends that say, look, of course we believe in that. And I think one of the interesting things about osteopathic medicine is that it's sort of become mainstream to the point that everybody is buying into or agrees with A.T. Still's philosophies. So they're not as earth-shattering as they were in the 1870s. Now, people look at the philosophy and say, of course, that's true, MDs and DOs. So the tenets of osteopathy, I'm just going to go through. We like to chant this, but the body is a unit, mind, body, and spirit together. And they recommend that doctors look at all of these things. The body is capable of self-regulation, self-healing, and health maintenance. Structure and function are reciprocally interrelated, and that rational treatment is based on these principles. So the bottom line is, I don't think anybody's going to argue that when you see a patient, you have to look at the whole patient, mind, body, and spirit. And gastroenterologist, but when a patient comes into my office, I try to engage with the patient. I try to make a relationship with the patient. You could argue that this is just because I was chief resident in internal medicine, but I always take time to make sure they saw their primary doctor, they had their mammogram, they had the cholesterol check. I'm really always thinking about the whole patient, not just the fact that the patient's coming in with rectal bleeding. So I feel that that's sort of my osteopathic background. What do I leave from the osteopathic philosophy? Nothing. I think the osteopathic philosophy is great. Part of my pride in being a DO is the reason that I started the podcast. I think that it's really a great way of thinking about patients. And the manual medicine, I don't practice. I always kid around. I've talked about it on a few interviews, but my son is 16 years old. And this is a little odd, but I'm going to share it with you anyway. My son is 16 years old. He wants to be a physician, not any push from me, but I would love for him to be a doctor. And he carries a very heavy backpack, which I'm frequently trying to convince him to stop. And then he says, Dad, my back is killing me. So at some point, he asked me, can you do some of that OMM stuff for my back? And I started doing some soft tissue techniques and occasionally a little high velocity thrusting technique. It's probably the only OMM I practice at this point. But he's a dick, got to leave me alone. I'm like, no, I just did like 20 colonoscopies today. I want to take a nap. And he's like, come on, Dad, can you just rub my back a little bit? It really makes me feel much better. But other than that, that's kind of not part of my practice.
There's critics out there who call osteopathy, and I think mostly they're talking about the manual medicine. They call it quackery. There's an article on Quack Watch about osteopathic medicine. What's your response to those who call it quackery?
Okay, so I would just start with the term quack. If you don't mind, I'll just define where did quack come from. So quack is Dutch for quackzalver. That's where it comes from, which is an unregulated practitioner who sold cures of dubious origin without a doctor's prescription. So my first response in the United States is that osteopaths are doctors. We're complete physicians. So it's not without a doctor's prescription. And it's not unregulated. So we have regulating bodies, et cetera, et cetera. When it comes down to evidence on our podcast, again, this is not my area of expertise. I can't quote papers on osteopathic medicine, but there is evidence. There is some evidence on osteopathic medicine. And I think many practitioners, there's a doctor named Jordan Keys, who's just awesome. We've interviewed her, and she's a great woman. She's at the New York Institute of Technology, College of Osteopathic Medicine, and she is trying to group together different practitioners to work on advancing research. She's trying to, a lot of DOs really are focusing now on evidence base for manual medicine, for osteopathic manual medicine. And I think it's super interesting. They know it's needed and they're working on it.
When I applied to medical school 25 years ago, I applied to both MD and DO schools, got into some DO schools, interviewed, was accepted. And the main explanation I heard when I went there was that, yeah, we teach you medicine. We also have OMM classes. Do you think DO schools should still be teaching OMM classes?
So 100% DO schools have to teach OMM classes. I think that OMM is part of our culture, our history. And I think it's important to have a perspective. And sometimes people come to see me and they comment that I'm a little more, and I am a standard gastroenterologist. I don't do anything different than an MDGI doctor would. But there are a lot of people that do a lot of different alternative therapies or complementary therapies. And I think just having been exposed to manipulation in medical school, I believe gives osteopaths not only an appreciation for manual therapy, but appreciation for other complementary therapies that may not be the standard of care in the United States, but that patients want and are seeking out. And rather than saying the practitioner that's talking about probiotics, which, we're looking to talk to you about GI things for a year, but microbiome is really coming to the forefront. Everyone in GI is talking about microbiome now. But if you asked someone about probiotics 2 or 3 years ago, they may have said, anybody who's using probiotics is a quack. There's no data. So sometimes it just takes time for the data to come. And answering your question, I think that it's integral. Manipulation is integral to our history. I think it's integral to who we are as osteopaths. And even if DOs don't practice it, I do think it's important to teach it in school.
Now, on average, based on objective data, test scores, GPAs, acceptance rates, et cetera, it's still a little easier to gain acceptance to a DO school than an MD school. What advice do you give to a student who's trying to decide which medical schools to apply to? Should they apply to only MD schools, only DO schools, both? What advice do you give?
All right. So first of all, I'm going to circle back to our first question about your question to me about finances. And I'm going to give like sort of a Jim Dhale answer, if that's okay. I don't want to be the white coat investor or take your spot. But again, I already told you my son wants to go to medical school, and he asked that question. He said, Dad, am I going to DO school or am I going to MD school? So my thought is, first of all, look at your finances. I think medical school is so expensive. I think that's got to play a big part into where you go to medical school. But number two, I think it's similar to advice that you give someone about choosing a college. You got to do your research. You got to see if the school offers you what you want, whether it be location, whether it be outside of school, the area that the school is in, whether it be, if you have a passion for a holistic philosophy, you should go to osteopathic school. If you have a passion for manipulative therapy and complementary therapies and you want to learn something more, I think you should look at osteopathic school. As you said, people go to schools for different reasons. Some people only get into one school. If you applied to MD schools and DO schools and you only got into DO schools, I think that's great. I think it's probably something that you should consider. But I think you have to look at all of those factors when you decide where you want to go.
Same advice once they get in. Say somebody gets accepted to a DO school and an MD school, same price. They're fine with either location. You'd tell them to make the decision based on philosophy and how they feel about it.
Yes, absolutely. I think at any school, the other thing that I would think about, and it's very difficult when you're applying to medical school, but you have to have some thought about maybe what you'd want to do. I would say what you want to do when you grow up. If you look, DO schools most of the mission statements are to produce primary care docs. If you want to be primary care, it's a no-brainer. But maybe if you wanted to be a neurosurgeon and you looked at, I would say, look at the school, see how many we have interviewed DO neurosurgeons. There are plenty of DO neurosurgeons, but that's not what the average DO goes into. Maybe look at the schools, see if things that you're interested in, people have gone into those specialties. And I would say the same thing for an MD school.
It's tricky too, though, because about half of us change what specialty we want to do at some point in medical school. I thought I was going to be an FP coming in. I ended up being an emergency doc. And I think probably half my class changed. Some of us changed a dozen times trying to figure out what specialty we were going to do.
Absolutely. You can't see the future. It's definitely difficult. Again, I thought I was going to do primary care when I first started as well. And I ended up becoming a gastroenterologist. So there's no perfect answer when you're picking a school. But I'm very proud of my education as far as going to osteopathic school. The ends justify the means. So you could only say if your choices were correct when you look at where you are at the end. So, and obviously, hopefully I'm not at the end, but that you can only, the ends justify the means. So looking back, I was very happy with my decision to go to osteopathic school at the time. And today I'm very happy with the school that I went to, my education and everything that I've built off of it.
Yeah. I've noticed a trend recently. There's now 3 medical schools in Utah. There's the University of Utah School of Medicine up in Salt Lake where I went, and there's 2 new DO schools, one in Provo and one in Southern Utah. It feels to me like most of new medical schools these days are DO schools. Do you have any idea why that is? Is it some sort of regulatory thing?
It's a great question, Jim. I would like to know the answer also. I do not know the answer. We recently interviewed, the interview hasn't gone up yet, but there is COCO, which is the accrediting agency for osteopathic schools. We interviewed a dean that is on COCA, and I don't think they actually have any input as to what schools are opened. You talk about this on your show. We need more docs in the US. A lot of docs go to South America or the Caribbean or other countries to train. We don't produce enough doctors in the United States, DOs and MD, to fill all our residency spots. So I have nothing against Caribbean schools, but I don't see why students in the US, if we need US docs, why we're not producing them here. So whether there are more MD schools or DO schools, I don't think that matters. I think either is great. And your question is, why aren't the MD schools increasing in size to fill that need? Why are the DO schools increasing? And there's definitely been a dramatic increase in the number of DO schools over the past 10 years, but I don't know why that is.
One issue with it seems to me that a large proportion of those DO schools, particularly the newer ones, they're not associated with their own teaching hospital. They farm out their students all over their region. They sometimes expect the students themselves to line up core rotations like medicine and surgery. with non-academic docs at community hospitals. Do you think that's a problem? And if so, what should be done about it?
Yeah, so I mean, I'll tell you from my experience. So I went to the New York College of Osteopathic Medicine. They did have a lot of affiliate hospitals where we rotated. There wasn't like one main core hospital. And for me, it was actually a great experience because I could pick and choose what rotations I felt were strong. And maybe if I just had one hospital, I wouldn't be able to pick those. As far as going into the community and not being in a big university, sometimes it does make research a little more difficult to get. So I actually did a lot of research in medical school, but I had to seek that out. Depends on the MD institution. I'm actually a professor now at an MD institution and a DO institution. It depends on its institution to institution. So I wouldn't say every MD institution allows you that research opportunity. But I do think that's something that the DO schools are working on and need to work on. As far as rotations, I don't speak for the American Osteopathic Association, ACOM, or any of the schools. But I think that if you're picking a school, if I was a student and I was picking a school, and I have students that I mentor that go to DO schools all the time, and I recommend that they really take a good look. I think it's so important to make sure that your school has strong rotations, strong affiliates with hospitals. If they are community, that's okay, but make sure that those rotations are great or those rotations are solid and that there's good placement for residency and fellowship after they leave. I think they just have to do their homework. As far as schools that don't have those affiliations, I think that's beyond anything I can comment on how to make that better.
Perhaps the biggest change in MD and DO relations came just a few years ago. I mean, the MD match has essentially been open to DOs. It was kind of phased in between 2015 and 2019. I think the DO match went away completely, right?
Yeah, there's a combined match now. That's
the
correct.
NRMP now. What recommendations do you have for a DO student as they approach the match process?
So it's so interesting. And I think that I've had a lot of, I'm going to say this like 20 times, but I'm not academic. I don't work for the NRMP, but I have a lot of students that I mentor. So I kind of try to keep my finger on the pulse and I do give them advice and I'm happy to share that. So it used to be, so when I applied for internal medicine, you could go through the DO match. There was a DO match. You could go through the NRMP or the MD match or however you want to call it, or you could actually be a free agent. So I actually signed outside the match. So it was really a nice thing. People said it was unfair. So I was offered a spot at Mayo Clinic. I actually signed my spot at North Shore outside the match. And you could say that that's really like, my wife would say that I cheated, like, I don't know, like it was a little loophole, it's not really cheating, but, so as a DO, it was kind of nice. You could sign outside the match. People felt that's not fair and they got rid of it. So there's now a combined match. So DOs cannot sign outside the match, there is no DO match. It's combined. So all of those DO programs, is it fair to MDs that MDs can't apply to those DO spots? How's that fair, right? That's not really fair either. So it is what it is. There's now a combined match. Another question that comes up with students are boards being pass-fail, and what do you do? I think my advice to DO students or any medical students, I have MD students that I mentor also, is always, it depends on what you want to do. So if you want to go into pediatrics and you want a rural experience that's not competitive, it doesn't matter that much. But if you want to go into pediatrics and you want to be at CHOP, you want to be at a competitive program, whether you're an MD or a DO, I think you have to do your best to try to showcase yourself at that hospital. I think you have to try to do research, which is the coin of the realm, and you have to do well on your boards. And even more so of those things if you want to go into a very competitive subspecialty like orthopedics or dermatology.
Yeah. Or GI, frankly.
GI
fellowship is pretty competitive too.
Yeah, so GI is interesting. So, and I think that's an interesting fact also. So I'm very big pro primary care. I think, I did internal medicine obviously before I did GI. I think the internist, the family practitioner, pediatrician, I think those are the most important people in healthcare. I know on your show, we talk sometimes about compensation for those things, and maybe they're a little less compensated than surgical subspecialties. But yeah, I think those are the most important people in healthcare. Those are the people that are seeing the patients and helping them get to where they want to be. We talk about a lot of DOs going into primary care, but primary care like internal medicine, pediatrics, a lot of people that go into primary care end up doing a subspecialty afterwards. So that I think that's a little misleading. GI, without being totally obnoxious, is the most competitive subspecialty off of internal medicine. Part of it because there are not as many spots as things like cardiology, but cardiology and GI are the most competitive. And if somebody wanted to do GI, it's like you get into that internal medicine residency, and especially at home, which is your best shot at getting a fellowship, make sure that you're known as a hard worker, make sure you care about your patients, make sure that you do your research and do well on your tests.
Yeah. I was fascinated by gastroenterology when I was a medical student and thought that would be a really great career, but there was no way I was going through an internal medicine residency to get there. I just could not round for 3 years. There's no way I could have done it. I wouldn't have made it through.
Jim, I love rounding. I'm an internist at heart. There's nothing better than rounding. And I'll tell you, it's so interesting when you think about choosing a subspecialty. Like I would never do emergency medicine. I just couldn't do it. And I'll tell you the reason. I'll tell you the reason why I couldn't do ER. Just like you can't do medicine because you couldn't round. I couldn't do ER because you have to make so many decisions on a daily basis, whether to treat the patient or send them home. And some of those decisions are really tough. I think it's really tough and it's very unforgiving. I think the system's very unforgiving. You can't admit everybody. And some people you're going to send home and they're going to get sick and need to come back. And you're judged on that.
Yeah. Well, now everybody's training basically in the same programs. After that training is done, after residency, what do you think employers and patients themselves should think about the medical degree of their doctors that they might hire? Whether they have an MD or a DO, do you think there's any advantage or disadvantage at that point that still remains, or should it just be ignored?
Once you get out of training, there's absolutely no difference. As far as patients, I've been practicing gastroenterology now for 20 years. Sometimes I think the only DO comments that I get, thank God I have a very busy practice, blessed that people want to come see me and have me take care of them. The only DO comments that come up, which are kind of funny sometimes, is once a year or so, patient will come in and say, I really wanted to see you because you're a DO gastroenterologist and I want a holistic approach. So there's not that much holistic approach to colonoscopy for screening, right? It's kind of like they're just, they're getting checked and we're taking out some polyps. But I always smile and, it makes me happy. But, as far as patients go, for most things, we're the same.
After you finished your training, you deliberately took one of the lowest paying jobs you were offered. Tell us why and how it worked out for you.
Yeah. So as you said, Jim, it's very competitive to get GI. I actually applied twice. So the first time I applied, I did not get a position. They offered me chief resident, which is a very prestigious teaching year. And then I reapplied the second year and got my fellowship at University of Miami, which I couldn't say enough about. So it was a really difficult road to get a GI fellowship. And then after I got out, there were like 250 job offers. Like people were falling over themselves to give me a job. And it was like, what's so interesting is I thought getting a fellowship was hard. And we're talking about, getting into medical school is hard and like maybe you only have one choice. Like that always seems terrible. But it was actually so much harder to pick a job and I just didn't know what to do. So ultimately I was offered, and I never looked at money when I thought about, maybe it was naivety, but I just did what I loved. I love GI and that's what I did. And when I got offered salaries, I was like, really? They're going to pay me that much to do what I love? That's great, But, a lot of the jobs that I looked at had restrictive covenants and turnover, had doctors that had turned over. And I interviewed with a doctor who was a fellow when I was an internal medicine resident. He was a fellow. He went off into practice with another doctor, and they had actually had a little bad divorce. and he was on his own. And I spoke to him. I actually came in for an interview as an attending physician working for the hospital, and I ran into him walking out, and he said, Storch, like, listen, I really got to hire somebody. I'm so busy. Do you want to? I know I had sent him a letter, I think, or called him. He's like, would you be interested in a job? I'm like, yeah, I would love to talk to you. So I sat and talked to him, and he said, listen, let me think about it, and I'm going to make you an offer. So his offer was, he sent me a contract, or sent me like a proposal, and it was basically, this is what I'm going to offer you. I don't really have a practice to offer you, so you're not going to have any patients. I'm going to pay you about half of what everybody else is offering you. I'm not going to make you sign a restrictive covenant. So if I mistreat you in any way, you can hang a shingle next door. I'm going to give you occurrence insurance, and you can build your own practice. And I really saw it as a great opportunity, and I really blessed with my wife. My wife's just a very, very supportive woman, and it was tough. We were like, I mean, Miami was great, but we were not living the good life in Miami. My salary, I think, when I graduated, and it's going back a number of years, but I think it was 24,000 or something like that. So in fellowship, sometimes the more prestigious the fellowship you get, the less they pay you, because they know you're going to come. But I told her, look, I think I could build my own practice, as opposed to taking this big salary and a restriction and taking someone else's patients and having them grow my business. I think I could do this on my own, and I think I could grow my own practice. And I think this is the way to go. I think I got to bet on myself. And my wife was supportive of the decision. It was a very difficult decision, but I took the job, and still have my own practice, still in the same practice. And looking back, I could not have been happier or done better with any of the other 249 jobs I was offered.
And financially, how'd you do? Did you feel like you came out ahead despite starting at a relatively low rate?
1,000%. No, there is absolutely no question that I would not be financially in the position that I'm in if I had taken any other job. Obviously, I can't go down those other paths, but I can't imagine I would be in as good a position as I am now. I believe, and this was my philosophy when I was looking at a job, was have a 5-year plan. Look at so sometimes students come to me, and they ask me for advice, docs coming out of residency, students that I've mentored in the past, or they find my name on the bathroom wall, and they're like, Storch, what do you think of this job? And I always tell them, like, don't look at, and again, this was kind of my own thought process, which I really feel is true. Don't look at that initial salary, because when you start off as a doc, that's not your top end. Your top end is going to be 5, 7, it depends on what you're doing, but it's going to be a few years down the road. So I think it's so important and as you said, like, even with changing your mind in med school, you may not be with the same job, but you want to take a job that you really think you're going to be with, because you want to maximize your chances of getting to that 5-year or whatever year that is, where you're going to have your wings fully stretched. And that's where you're going to do the best if you get to that point. So if you're bouncing job to job, you're never going to get there, and your earning potential is going to be much less. So fortunate that I built my own practice. I didn't owe someone, I didn't have to buy into my practice. I didn't have to give someone, my partner, that was the other piece. There was no buy-in. It was sweat equity. So he made some money off of me for a few years. And then whatever I had was mine. And if I wanted to leave, if, we had a disagreement, I didn't have to give up that 5 years or whatever years of reputation that I had built. I could keep it and stay. So it worked out great.
Yeah. A lot of people, I think, don't realize there's value to a non-compete. Now, it sounds like they're probably all going to be outlawed soon anyway. But there's value. You got to get paid more if you're signing a non-compete, because you're losing something when you do that. So they should pay you more if you're having to sign non-competes. Absolutely.
I think advice that I would give or that I regularly give, you have to know yourself. And this may sound sort of negative, but you have to know, are you the person that just needs to be employed? You just want to come in, you want to check in, you want to do your thing and go home, right? Or are you the person that you're going to hustle, you're going to stay late, you're going to put in 110%? Because there's nothing wrong with, being an employed doc. And I have my own practice. There's a lot of business pieces that I have to do. Those things take a lot of time. I love it. I wouldn't trade it in for anything. But you have to decide, like, do you want to bet on yourself? And if you really believe in yourself and you really know that you're awesome, always bet on yourself.
Do you have any other pearls? I mean, as a private practice doc, there's not that many of us left. As a private practice doc, what pearls do you have about contracts, partnership, working with insurance, et cetera, that you've applied in your practice over the years?
Yeah, so I would say coming into practice, you just mentioned the restrictive covenant. We'll see what happens with that. As you said, that may or may not go out the window, but that would definitely be great for people coming out if it does. But as you said, for me, not having a non-compete was great. When you become a partner, part of the problem is, and it's interesting when you're looking at a job. There was a practice that actually offered me a letter of intent. So practices don't tell you, or they're not going to legally tell you you'll be partner at year 5 and this is what it'll look like, because maybe things won't work out. But there was a practice that offered me a letter of intent of this is what partnership will look like. My attorney told me that had no value, but in retrospect, I thought it was real nice. So I think it's a nice thing to have in writing, what partnership's going to look like. Private practice, as you said, there's not that many of us around. Most docs, majority of docs at this point are employed. I think there's great value in private practice. It's an effort. It's extra work. It's not easy, but I think that there's something extra that you can offer to your patients as a private practice doc. And don't get me wrong, I have plenty of colleagues and friends that are employed and practice like a private practice doctor. But, private practice doctors in general, because it's theirs, if it's 5 o'clock, 6 o'clock, and like today, I had office hours. A referring doctor called up and said, "Storch, I have somebody in my office. I know you probably have an interview with Jim Dhale later today, but can I? They're having an issue. I would love if you could see him and send him over." You may not have that ability if you're employed. Maybe look, the office closes at 2:30 because we have an interview with Jim Dhale. So sorry, you can't see that extra patient. Waiting times for procedures. My practice is very blessed. We're busy, but we can always, somebody comes in, and I got a phone call today. A patient is having a kidney transplant. They really need to get their colonoscopy before the transplant. No one else will do their colonoscopy. Everybody else is booked out for 2 months. Of course, we're going to take care of that patient and make sure that they get what they need. So I think those are, people talk about private practice going away and there not being private practice anymore. I guess that's possible. But, in my opinion, I think there'll always be that niche of the extra value add that private practice can give. And as far as insurances, the negative to being in private practice, I think most docs in general, with an IPA or a physician organization that helps them get better contracts. Obviously, those things are always helpful, and you can do that and still be independent. Definitely, hospital systems can negotiate higher rates, and many times organizations that want to acquire my practice will point that out. But the question for those situations, for big groups that hire docs, is that, are those monies actually going to the doc? So even if they're making more money on the procedure, is the doc actually seeing that money? That's question number one. And the other question that I always think about is, patients have high deductible plans. They have responsibilities. I think it's important, or at least in my practice, it's important to sort of provide great care at the lowest cost possible. And that's for the healthcare system at large, for the insurance company. They look favorably on people that are lower cost providers. You could do it for less. Like, don't do it in the hospital. If you can do outpatient procedures instead of doing them in the hospital, saves money when clinically appropriate. And for the patient, patients have high deductible plans for a lot of things. So it's unfortunate that patients are consumers, but they are. And I think you can help more patients have access to care and get the care that they need if you provide lower cost.
One of the best things I like about private practice is just control. As you move through your career, the control matters. You get less burned out when you have control over your work environment and how much you're working. And I think that's the best part about being in private practice, that new grads don't realize how important that's going to be to them in a few years.
Yeah, so just 100%. So that ranges from recently, one of my endoscopy technicians said, "You know what? It would be great if we had another pediatric colonoscope. What do you think?" I said, "I think that's a great idea. I think we should. Yes, we should have an extra pediatric colonoscope." And I called up my scope rep and I told them, "Look, can you send us another scope?" And we cut him a check and we got a scope. There's no red tape. That was a great idea. We got a new scope. On the other side, I have a good friend who was in private practice. He's with a hospital system now. And I remember when he first joined, his son had a hockey game 2 weeks from the date that he found out about it on a Friday. And he went to his office manager and said, "Listen, my son's in the hockey championship 2 weeks from now on Friday. I need to take the day off." She said, "No." And he said, "What do you mean, no? Like, it's 2 weeks from now. And, I really want to be there for my son and spend time and go to his hockey game." And she said, there's a policy in the office. You need to give a month notice for elective and you already have patients booked and you can't take that day off. So, I don't know that people realize that, when they sign up.
Yeah, those sorts of situations are very burnout inducing. What else helps to a lot of people with burnout, though, is having some sort of a side gig. And I know you've done some. What do you see as the role and the benefits of side gigs in a career for a doc?
Yeah, so burnout's so interesting to me. I would say, first of all, like we all know burnout's a huge problem. I think the best way, and I'm not answering any of your questions directly, but I'm going to come back. The best way to avoid burnout is to do what you love. I think you got to pick something that you love. So it's always interesting when I speak to students and they're like, "What do you think I should do?" And maybe they're going on a Medscape search and seeing what docs are making the most money or have the least hours. I think those are like bad ways to make a decision. I think you got to try everything on. As you said, you may change your mind 15 times, but pick what you love. I love coming to work. I love gastroenterology. So, I mean, God bless. I've been doing this for 20 years. I work a lot of hours and I don't think I'm getting burnt out. But, I definitely think having outside interests and doing other things is amazing. I definitely think it's true that it avoids burnout. The term side gig is always interesting to me. So I don't know that I have side gigs. Side gigs would be like if I worked at McDonald's on top of my GI practice. So most of the things that I do outside of my clinical practice, and I can call them side gigs, but they're kind of like affiliated ventures. So, the great thing about GI, and I know you said you didn't want a round to do GI, but the thing that's so appealing about GI is, I have my practice, I see my patients, I have relationships with people, but then on the side, I get to do cool procedures. I mean, that's just fun. And part of that is the tech of GI. So I've always tried to stay involved with companies that are developing tech, and little interests of mine are like capsule endoscopy, which I've been very involved with since it was FDA. I mean, the idea that you can swallow a little movie camera that takes pictures of the small intestine as it goes through and give you diagnostic information is super cool to me. So I have had some ability to work with some companies to develop different technologies specifically for capsule endoscopy, which has been great. And sort of early in my career, another thing that I was able to get involved in was defending doctors for malpractice, which that's like such a hard time for any of us. That's sort of like the dark times for a doc, and whether we like it or not, we're all going to end up, most of us, in some sort of malpractice suit, whether you do something wrong, which happens sometimes. Like I said, I couldn't be an ER doc because at some point you're going to send somebody home that if you look back, maybe it looks like you shouldn't have, even though at the time it was the right decision, or you didn't do anything wrong and you're just getting sued. So I was very interested in medical malpractice. I did a lot of work defending doctors, again, early on in my career, and ultimately fortunate to be brought onto the board of directors of a malpractice, a company that insures doctors for malpractice. And it's just been such an interesting thing to be involved in the business aspect of a company. And just, I definitely think, it's all these things are time. I'm blessed that from a financial perspective, my wife hasn't divorced me and taken half my money. That's always a good thing. Like she's actually sometimes a little less happy when I actually am home. She's like, don't you have something else to do? We have our own thing going on. So we're kind of yin and yang and work out. But greed burnout for me is definitely less because I stay interested in a lot of different things.
We've been talking with Dr. Ian Storch, the podcast host of the DO or Do Not podcast. And it's been great to have you here. Obviously, people can look up that podcast. They want to hear more from you. Do you have any last words of advice for people before we let you go and get to your scopes this afternoon?
Right. So I'm going to give one little anecdote. So if that's okay, one little story. So, people ask me if I think I'm successful or what doctors are successful. And I think it's very difficult to rate success. And this is from New York College of Osteopathic Medicine, my osteopathic school. When you're in school, the biggest bond that you have, I think, for many students is in your anatomy pod, Jim. I don't know if you remember your anatomy pod, but it's like, right? It's like 5 guys or gals put together, and you spend a ton of time digging and finding nerves and arteries, and it's very difficult, but you really form a tight bond. And those many times I think are your besties, right? Do you have those or?
Yeah, absolutely. Although I'm not sure it took precedence over the friends at the foosball table, but yeah.
Right. Sure. All right. Foosball tables is, I only have time for one story, right? So my anatomy group, which I always think is so interesting. So my anatomy group, we really bonded. And, of course, you get older and everybody has their career and their family. You don't see each other as much as you like. But I always have this little story that I tell people. And the question, the framework is, who's the most successful? All right. And I'll just tell you, I just think it's so interesting. I think about this a lot. So you got me, you got Ian, right? So Ian, you heard my story, NICOM, internal medicine at North Shore, University of Miami, GI private practice, right? Great. And then my buddy Joe went to NYU Long Island for medicine. He did cardiology there. And he ended up going to Mass General. He went to Harvard for electrophysiology, and he's now an employed EP doc. So that's top of the line cardiology, dare to dream. That's what you do. My friend Pat, who's actually my roommate, he hated rounding, Jim. So he agreed with you. He ended up doing ER at Lenox Hill. He went out into practice on Eastern Long Island, and he decided he wanted to do administration. So he went into administrative position. He is now president and CEO of a large healthcare system on Long Island. Pretty impressive, right? Then the other two, Bob did family practice at a community hospital. His grades were spectacular. That's what he wanted to do. He spent 3 years in family practice. And one day he went to get a hair transplant on Park Avenue. And the guy, this is a true story. You can't make this stuff up. And the guy was thinking about retiring. And he said, he told him he was a doctor. He said, do you know what you want to do when you finish? And he said, no, I don't have a job yet. And he said, maybe I'll teach you hair transplant. So he learned hair transplant, and he took over the guy's practice. He's now doing hair transplant on Park Avenue. That's pretty cool. And then the last doc that I had in my anatomy pod was Adam. Adam did internal medicine. He went into primary care. He has a beautiful practice. He's still a very close friend of mine. And, when we go out to dinner at a restaurant, he's got a beautiful house. He's got a beautiful wife. He's got a beautiful kid. And we go out for dinner sometimes. And every time we go out to a restaurant, a patient comes up to him and says, doc, you saved my mom's life. He's like a celebrity. Like everyone loves him. And I am so blessed that I'm even sitting at the table with him. And I'm always impressed at these people. And he's so humble, amazing. So, I think you have to decide, I think it's such a cool story because there's no right answer to what makes you the most successful. And, I always think about who the most successful person in our anatomy pod is. And I don't have an answer.
Awesome. Great anecdote. Thanks so much for your time and for being on the podcast today.
Thanks for having me, Jim. I appreciate it.
Okay, I hope you enjoyed that interview as much as I did. Dr. Storch is great. And while we kind of made the title of this podcast a little bit clickbaity, I think as we've seen over the last 100 years, the MD and DO streams of doctors have really merged more and more and more and more. And it'll be interesting to see over the next 20 or 30 or 50 years any other changes that may come with the merging of those two branches of medicine.
This concludes our episode of Do or Do Not. Send all inquiries, comments, suggestions, and even let us know if there is someone you want us to interview to doordonotpodcast@gmail.com. Don't forget to like us on Facebook at Do or Do Not Podcast for updates. If you enjoyed our podcast, please share it with your classmates and administration. We have plenty of more interviews lined up, and we're excited to share them with you. This is Tian Yu Shea. Thank you guys so much for listening to Do or Do Not.